একজন বল কি দেখলি? This is a central venous catheter. This is a central venous catheter kit. এবার বাকিগুলো দেখে বল সাইজ কত ফ্রেঞ্চ? 7 ফ্রেঞ্চ মানে ইন্টারনাল ডায়ামিটার কত? 7 ফ্রেঞ্চ মানে 2.40 1 তাহলে কত হচ্ছে? 1 মানে 7 দিয়ে ভাগ করলে 0.34 আগের দিন বলেছিলাম কিন্তু একদিন 1 ফ্রেঞ্চ মানে কত? সেই ইউরিনারি ক্যাথেটার পড়াতে গিয়ে পড়েছিলাম, লিখে রাখ, ভুলে যাবি। লেন্থ আচ্ছা আচ্ছা, কি কি আছে? না না, কন্টেনিং সেন্ট্রাল ভেনাস ক্যাথেটার, one central venous catheter,
which is radiopaque and triple lumen. তারপর হচ্ছে one nitinol core.
radiopaque কেন?
radiopaque কেন কি স্যার?
যাতে এক্সরেতে ধরা পড়ে, so that it can come into the chest X-ray to see whether the catheter is placed in the right place or not.
One nitinol core J-tip guide wire, one Y-type introducer.
J guide wire, flexible guide wire made of tungsten. লেখা আছে tungsten wire. J মানে J size. Tip of the catheter is, দেখা যাচ্ছে? Can you look? Can you see this? Catheter. Now this is now in the inside the lumen. Tip is not showing. J shift মানে J এর মতো, the tip will be like J shaped. Okay.
Y-type introducer needle, one dilator, one
Introducer needle. Key type? What type?
Y-type.
Y-type introducer needle. বা beveled introducer needle. Size লেখা আছে না? 18 gauge size.
18 gauge into 70
Length is 70.
Length is the 17 millimeter. Yes.
One dilator, 8 French into 90 millimeter. One scalpel.
Dilator should be always, size of the dilator should be always bigger than the size of the central venous catheter. Needle is, how needle size expressed in which unit? Gauge. This distal end is 16 gauge. What depends the size of the gauge? Flow, rate of flow. If it is 16 gauge, its rate of flow 60 ml per minute. If it is needle size is 18 gauge, then flow rate will be 25 per minute, 25 ml per minute. Each is 18 gauge. That is also this catheter size, distal catheter size is 16, so flow will be 60 ml per minute. Medial is 18, so 25 ml, and why length is 16 centimeter? It is the length between introduction size and the level of right atrium. Level of right atrium. Where is the level of right atrium? Surface marking. It is in the fourth intercostal space at the in supine position at the level at the mid axillary line. Okay. Fourth intercostal space. Apex bit তো এই বাঁদিকে থাকবে। এতে তুই ইউজুয়ালি আমরা ইন্ট্রোডিউস করি ইন্টারনাল জুগুলার ভেনারের রাইট সাইডে, সেটা আসছে আমি পরে। Fourth intercostal space. Apex bit তো mid axillary line. Mid axillary. তো somebody says fifth, somebody says fourth intercostal space. It is the level of the tricuspid valve, by level of the right atrium. So, central line by central interaction of what is central line? It is the interaction of a catheter, is called central venous catheter, to place the tip of the catheter at the junction of the central vein like SBC or IVC junction with right atrium. Not in the right atrium, just at the junction of the right atrium. There are two central veins. One is superior vena cava, another is inferior vena cava. So, what is the purpose of indications of introduction of central venous line? Number one, fluid status or venous return. Fluid status. Number two, right ventricular function. Now, it reflects right atrial pressure, right ventricular end-diastolic pressure, and venous pressure of the venous. So it is affected by the venous return or fluid status of the central vein, or right ventricular function, or interthoracic pressure, and also position of the patient. It changes with the position of the patient. What are the indications to place the central venous catheter in patient? It is usually used in intensive care therapy unit to monitor, number one, indication to monitor the central venous pressure. Number two, to give parenteral fluid, like in total parenteral fluid, to give some important drugs like inotrope, vasodilator, potassium, which cannot be given in the peripheral vein due to its inflammatory properties, like it causes in the peripheral vein phlebitis, or accurate dose through the syringe pump cannot be given through the peripheral vein. It is also used in giving some chemotherapy. It is also used to give some antibiotic in prolonged cases like endocarditis, like osteomyelitis, prolonged use of antibiotic for 2 weeks, 3 weeks. Or sometimes it is used as a route. Catheter is another, like temporary pacemaker and plasmapheresis or dialysis. But this catheter is not. Catheter is another. Now, what is the normal center? Now come to venous pressure. What is the normal venous pressure? It is either described in millimeter of mercury or described in centimeter water. 1 millimeter mercury equal to how many centimeter of water? 1.36 centimeter water. So normal central venous pressure is 2 to 8 millimeter of mercury, or 5 to 12 centimeter water. 12 centimeter water or 2 to 8 millimeter of mercury. When you call low central venous pressure, when the central venous pressure is below 2 millimeter of mercury, or high CVP, when you call high CVP, when it is more than 10 to 12 millimeter of mercury. What are the causes of low CVP? One is shock, one is hypovolemia, another is either it depends two factor. One is volume status and another is venous tone. Hypovolemia, shock, and the condition where the venous tone is decreases. The relaxation, more capacitance, more volume. And what are the causes of high CVP? First cause is fluid overload, increased venous return, fluid overload. Next is, already I have told you, the central venous pressures indirectly depends on parameters like fluid status, like heart condition, particularly right side, right ventricular condition, and intrathoracic pressure and position of the patient. So it will increase in volume overload, right ventricular failure, number 3 pulmonary hypertension, or number 4 cardiac tamponade, বা pericardial effusion. পাম্প করতে পারছে না। Central venous pressure is a monitor of a hemodynamic monitor. It is used next slide. It is a sterile procedure. Okay, so it does not directly reflect this volume status or condition of the heart or it is a relative indication, not absolute indication. How it can be used practically? Like suppose a patient comes with shock or hypovolemia, you give a fluid challenge. If this fluid challenge improves not only the central venous pressure but also the clinical condition and echocardigraphically, what are the clinical conditions that you can tell that the patient improves from fluid hypovolemia or shock? Vital signs like pulse, blood pressure, temperature, cold clammy skin will become warm, oxygen saturation, urine output. These are the things you have to correlate with the central venous pressure monitoring. And also you can assess more sophisticatedly in the intensive therapy unit cardiac catheterization, like pulmonary capillary wedge pressure, which indirectly reflects the left ventricular endostolic pressure, provided there is no mitral stenosis. Now come to the how will you introduce the central venous catheter into the patient. Before that, tell me what are the different method to measure the central venous pressure. 1, 2, 3, 4. One is clinically, that is engorged jugular vein, neck vein, neck general survey, neck vein, which neck vein? That is internal jugular vein. Whether there is engorgement of the jugular vein above the sternal angle, or if you very expert, you can detect the trussing or waveform of the jugular vein or the waveform, or this is one method of clinical method, rough method. Next, you can measure by introducing the central venous catheter at the junction of the right atrium with the central vein like IBC, SBC, which is divided into two processes. One is manometric process, another is transducer process. Manometric process, there is a manometer with a fluid column part, and transducer is electronic transmitter which converts mechanical energy of the blood into electronic energy and reflected into the monitor. I coming to the details later. 1 to 3 methods. One is clinical method, one is transducer method, one is manometric method. Both manometric and transducer method needs in situ central venous catheter in the SBC or IVC. And another method is non-invasive ultrasound method. How it can measure? It can measure by measuring the diameter of the IVC and collapsibility of the IVC. If it is, if on ultrasonography the diameter of the IVC is more than 2 to 3 centimeter, then you can call there is increased central venous pressure, and if there is reducibility of the IVC or compressibility, rather compressibility of IVC, you can call also that is an indication of increased central venous pressure. Now, method of introduction of central venous pressure. What are the 3 routes where you can introduce? 2 in the upper part of body, that is SBC, 1 is lower part of the bodies, that is IVC. SBC either through the internal jugular vein or subclavian vein, and IVC through the femoral vein. Now you have to know the little bit of anatomy, surgical anatomy or surgical landmark of the anatomy of the internal jugular vein, landmark or landmark of the subclavian vein, and landmark of the femoral vein. Then now come first with the internal jugular vein. In case of internal jugular vein, always it is preferred in the right side. Why it is preferred in the right side? The internal jugular vein at sternocostal sternal angle joins with the subclavian vein to form brachiocephalic vein. In right side, its course is very straight. In left side, course is not so straight. That is, so introduction through the right side is easy. Then, where you look for the internal jugular vein? Sedillot triangle. It is introduced in the right internal jugular vein in the neck. What is Sedillot triangle? Triangle means 3 arms. One arm is the medial third of the clavicle. One arm is sternal head of the sternocleidomastoid. One is the clavicular head of the sternocleidomastoid. The internal jugular vein lies in this triangle. It lies anterior and lateral to the carotid artery. You have to know the position, otherwise you can injure the carotid artery. You can injure with that carotid artery. This is a triangle. Triangle is a big part. So needle, you introduce needle. Needle will be small. Then where is the entrance point? Where will be entrance point? I am describing first the method in the internal jugular vein, right internal jugular vein. Apex of the triangle. That is where 2 heads sternocleidomastoid meets. Okay? You just see, this is the apex. 2 head meets. 2 head meets. That is the point where through you introduce the needle and catheter and guide wire. Then start with the process. What will you do? This is a sterile technique. Infection in the central vein is very dangerous. It causes thrombosis or venous obstruction. One is blind method, another is you can use ultrasound guide. How you differentiate between vein and artery in ultrasound? Madam? How can you differentiate between a vein and artery on ultrasound? Otherwise, how can you, what will help the ultrasound guided? Eh? 1 point. Borrow means it is relative to the artery, and size will be depend on the size of the patient, age of the patient. Artery is not compressible to the ultrasound or probe pressure. Vein is compressible to the probe pressure. By that you can differentiate. This is a subclavian internal jugular vein, and this is carotid artery. This is because it is a sterile technique. First you wash your hand, then before washing hand you wash your hand, then ask the sisters to put you gown, and before washing you put cap mask, and after washing you wear a gloves, then dressing with betadine or chlorhexidine, usually chlorhexidine because betadine some reactive if he goes into the vein. Then dressing draping of the patient, then position of the patient. Before position, you must check your what are the materials you should require. Number one is a what are the kits in written? That is a central venous catheter, one is guide wire, one is dilator, one is guide wire, dilator, one is syringe, one is syringe, 5 cc syringe, one is needle, that is bevel needle. This is called introduction needle. Sometimes may use somebody a preliminary needle to check the blood and smaller size of the needle. Except this, what you need some local, and needs a local 2% lignocaine and a needle and small size of the needle, that is 24 gauge. This is size is 16 gauge. Introduction needle size is the 16 gauge, and for infiltration of local you need 24 gauge, smaller needle, and with 2 cc syringe, 2 cc or 5 cc, 2 cc syringe usually. And then you take the local anesthesia at the apex, you 2 cc local lignocaine, then you take the introduction needle. Before that, position of the patient is 10 mm position, 15 degree, 10 mm. Why 15 degree, 10 mm position? One is to engorge the vein, distension of the vein. Like if you increase the leg, there is venous. Increase the upper part of the vein will be engorged, and another is important is to prevent air embolism. Air will move so that air will not go to the brain or upper side. Then how will you introduce the needle? It is 40 degree plane, direction will be toward the sternal angle or towards the nipple, just superficial, and you introduce the needle until blood comes. What type of blood? Venous blood. How will you confirm that it is venous blood or arterial blood? Venous blood will be dark and it is continuous flow. Arterial will be bright red and it is pulsatile fluid. If you accidentally puncture the carotid artery, you will immediately withdraw and give a pressure and try another attempt. Of course, not more than 2 or 3 attempts. Otherwise, you ask your expert seniors or go for another site like subclavian or femoral site. Then after the needle is introduced into the vein, you give a negative pressure that blood comes and steady the needle so that it will not move. Then after steadying and confirming that the continuous dark blood is coming through the needle, you take the J7. Oh, before that, I told you what are the measurement. You take the measurement from the site of introduction to the 4th intercostal or 5th intercostal space, up to which level you introduce the catheter. Usually in adult cases, the catheter is made company like that length. Then he introduced the catheter, a guide wire through the needle and remove the needle, keeping a pressure with a thumb so that there is no bleeding in the through the puncture site, and take a soaked chlorhexidine soaked gauze to wipe the guide wire so that no blood is contact with them, the blood clot go into the inside. Then how much you introduce the guide wire? You have to introduce up to until there is no ventricular ectopic or ventricular tachycardia which is monitored in the ECG. Otherwise, it will not go through the tricuspid valve. It will resist to the. If it goes into the right ventricle through the tricuspid valve, there will you see ventricular ectopic, and you withdraw somewhat. Then you give a small incision below the guide wire into the skin side so that dilator can go. Then you introduce the dilator into the subcutaneous skin, below the skin and into the subcutaneous plane, just up to the clavicle, so that the catheter can go easily into the internal site, and there is a tract also developed into this. Then you guide wire, how can you dilate the passage, how you dilate? Corkscrew movement. Again and again corkscrew movement. One introduce, again withdraw, again introduce. But guide wire should be in place. Guide wire, you should not lose the guide wire, and end of the guide wire should be outside. Otherwise, whole guide wire introduced, then you have to go for surgical removal of the guide wire. And always you keep a 2 finger to catch it, that the whole end should not go, and introduce the guide wire, dilator through the guide wire, so but end remains outside, and put by corkscrew movement, through movement, then you put through the, then you put the catheter into the, then you remove the dilator, then you put the catheter in the pre-procedure determined length through the guide wire. After you remove the guide wire and take a syringe, draw the blood, whether the venous blood is coming or not, then flush with the heparinized saline so that the lumen is not blocked. It is usually three-way channel. Eta kota channel? 3 আছে, 3-way channel for giving fluid or for giving inotrope, and one is for measurement of the central venous pressure. Now you have to fix. You have to fix the guide wire by suture. Here a suture also includes by suture at the junction of the খুলে দেখাতে পারলে ভালো। এই শুরুতে যেটা আছে একটা খাঁজ মতো থাকে, সেই খাঁজে স্কিনের সঙ্গে সেলাই করে ফিক্স করে দিতে হয়। আর দুদিকে দুটো এরকম ইয়ে থাকে, তোর আর্ম থাকে, তাতে সেন্ট্রালি ইয়ে থাকে, হোল থাকে, তাহলে এই তিনটে ফিক্সেশন হয়ে গেল। তারপরে এটা গজ, তারপরে কি করতে হবে, দেন আই হ্যাভ টু মেক দ্যাট চ্যানেল এয়ার ফ্রি, draw the blood and give normal saline through this port, and all the ports should be closed. Then one port is connected to the fluid filled column. Now we have to measure and monitor. How do we measure and monitor? You measure through the কিসের হাসির কিসের, হ্যাঁ কি হলো কিরে কি বল, কি প্রবলেম? এনিথিং প্রবলেম উইথ মি? হ্যাঁ না, ওকে। Then one channel, tibial lumen channel is connected with fluid filled column. Then the fluid filled column connects with the transducer. Then from transducer a cable is connected to the monitor, and which in monitor you can give the picture of waveform and pressure, written in the pressure. Now, how can you monitor the pressure? One thing is you have to zero the transducer to the atmospheric level. Otherwise, it is cannot be. This is better practical demonstration. Zeroing and leveling. You have to zero the central venous transducer and leveling. Leveling, that is, because central venous pressure is dependent on the position of the patient, you have to, transducer should be at the level of the right atrium or at the level of the tricuspid valve. That is, I have already told you, that is the fourth intercostal space in the mid-axillary line. And you can give patient supine. There is a rod where you fix the transducer, and patient is lying in the bed. This is the patient. This is chest, and this is a rod where you fix the transducer. Fluid feed column we connect here, and cable connect here, and that is with the monitor. Okay. You keep the transducer at the level of the patient's right atrium, in the fourth intercostal space. Okay, understand? Anything? You should go to the intensive care unit and see the things. These things should be taught in the intensive care unit. This is a indirect technique of method. If you see how to introduction in the OT, you have to see this is usually 2 days done by anesthetist. Because ex-executive of CTVS, in our MCH studentship, we have to do much of the things. Central in both through the jugular vein and both the subclavian vein. আচ্ছা, কোথায় ছিলাম? Now, before his question, leveling, zeroing, and monitoring. Then monitoring should be continuous process, not a single monitoring. Continuous monitoring. And depending on the continuous monitoring, your treatment plan will be also will be varies. Because it is introduced most of the cases of intensive care unit or cardiothoracic surgery unit. There is a multi-channel monitor which can measure CVP, arterial line, ECG. One monitor can measure all these things. So, what are the things? This is the one, internal jugular vein, surgical anatomy, technique, things required and technique of monitoring. Now come to the subclavian vein. Subclavian vein. Usually right side preferred. Why? You can choose any side, but book teaching is right side preferred because thoracic duct is in the left side. Chance of thoracic duct injury is less in the right side. Now, surgical landmark or surgical anatomy of the subclavian vein. It is below the clavicle, above the first dip, and behind the subclavian there is subclavian artery. Subclavian vein runs between the inferior surface of the clavicle and superior surface of the first dip. Superior surface of the first is at the junction in the medial third of the infraclavicular. The choice is in infraclavicular side. By the way, I পরে ভুলে যাব এখন বলে রাখি, what all are disadvantages, all the things disadvantages than the internal except one, that is superior surface and inferior surface of the middle third of the subclavian vein is attached with the clavicle and attached with the first dip. So chance of collapse of the vein is much less than the other vein in a state of hypovolemic shock. So it is preferred in the hypovolemic shock, but chance of all the complications is more in subclavian vein in comparison to the internal jugular vein. What are the structures lies between the subclavian vein and the subclavian artery? Anatomy. মুখটা একদম পেঁচার মতো করলে বাতারে পাঠিয়ে দেবো তোকে আমি। আমার কাকা অনেকদিন আগে সেই মুরারি মোহন মন্ডল, আমি তো রিটায়ার করেছি, আমার কাকা বোধহয় কবে মারা গেছে। মাধব না কি স্কুল আছে না, হাতার মাধব স্কুল, ওই কদিন আগে দেশের বাড়ি গিয়েছিলাম, নামটা ভুলে গিয়েছিলাম, ডাক নামটা মনে ছিল, স্কেলিনা সেন্টেরিয়ান অ্যান্ড because you have to know the little landmark of the anatomy and little landmark of the artery and vein to prevent the injury to the artery and to prevent the injury to the pleura, to prevent the injury of the brachial nerves or brachial plexus. Now, how will you introduce? What is the, like internal jugular vein, what will be the introduction point? 2 centimeters below the clavicle, at the junction of either somebody says it is the middle of the mid clavicular point or between the medial third and the middle third of the clavicle. Yeah, and then you push the same. I will not go through the anesthesia and sterile technique, anesthesia, dripping, gloves, all the same, and check your checklist, all the same. And now introduction, I am not going that part. I would say মাথায় ঢুকছে না তার মানে এখনো লম্বা সেন্ট্রাল ভেনাস প্রেসার ওভার আর্টারিয়াল লাইন লিখেছে, এই ওইখানে পৌঁছতে অনেক দূর চলে যাবে, ওইটা লাস্টে, ওইটা আরো বেশি শক্ত কমপ্লেক্স। তো I will give infiltration below the mid clavicular line 2 centimeter or middle third or medial third, then into direction of the our aim should be the between the first dip, superior surface of the first dip and inferior surface of the clavicle. The direction should be horizontal and towards the sternal notch. তার মানে কি হবে, এটা যদি আমার স্টার্নাল হয়, এটা যদি আমার ইনফ্রাক্লাভিকুলার হয় স্টার্নাল, এটা মিডিল থার্ড, এইভাবে আমি যাবো হরাইজন্টালি। যদি আমি যদি রেজিস্ট্যান্স, ইফ আই ফিল রেজিস্ট্যান্স, that means I hitting the bone, then introduce this technique is called, both in internal jugular, both in subclavian and both in femoral vein, technique is called modified Seldinger technique. You know the difference between Seldinger and modified Seldinger? Seldinger technique is technique is usually used in the arterial line. That is, you puncture both the wall, anterior and posterior wall. Then withdraw the give negative pressure attached to the syringe attached with the ear, and when blood comes, then you will be sure that it is in the lumen. But modified Seldinger technique is not to puncture the both anterior and posterior, only to puncture the anterior and introduce and keeping negative pressure to the syringe. When blood comes freely, that is dark blood, continuous flow, then you are sure that you are in the lumen of the vessels or vein. This is called modified Seldinger technique. That is called Seldinger technique, right? Otherwise you will forget. And Sedillot strangle, right? You write down the Sedillot strangle. নামটা লেখ, বাকিগুলো সব পেয়ে যাবি বইতে। Sedillot, SIDLLOTS, Sedillot strangle and Seldinger and modified Seldinger technique. Seldinger, SELDINGERS, Seldinger, R-S na, R. Seldinger or modified Seldinger technique. It is a technique to place catheter or gelco either in the artery or in the vein. Then other part of the procedure is the same, like internal jugular vein, like fixation of the catheter and connection to the transducer, connection either to manometer or electronic transducer, and fixation and monitoring, zeroing, positioning, all are the same. Okay, now come to the femoral vein. Where femoral vein lies? Femoral triangle. Femoral vein lies in the femoral triangle. So, what is the content of femoral triangle? Lateral to medial. No, don't describe it haphazardly. Laterally nerve, then artery, then vein, then lymphatics, then empty space. Navely. Mnemonics এটা খুব একটা পপুলার নয়, ওদেশে চলে। Navely. Nerve, artery, vein, lymphatics, and empty space. Where it is introduced? Below, just below the mid-inguinal point. Why not above the inguinal point? That is, if there is puncture of the artery, the blood will go into the retroperitoneal space, which you cannot control by pressure. Then you select the point. Why should we avoid the femoral vein for central venous line? Infection, because it is near the inguinal region and inguinoscrotal region, there is chance of contamination, and another thrombosis, because due to gravitational force there is thrombosis, or if any case there is increased intra-abdominal pressure, compresses the IVC. Same process, place the catheter in the IVC or junction of the RA. Now, complications. What are the complications of? One is problem. You have done a central venous line through the internal jugular vein, and after 3 to 4 hours, sister in the intensive care unit call you that the patient is complaining of dyspnea. No, you have completed the process and everything you done, and go for your lunch. After 1 or 2 hours, patient is complaining of difficulty in respiration, and on duty doctor or on duty nurse calls you. You come, and what is your suspect? What is the diagnosis? Diagnosis is the hematoma in the neck. Significant hematoma due to puncture of the carotid artery. You have not, you did not detect during the procedure, or there is multiple procedure and later forms the hematoma, and press on the respiratory passage. What is trachea? The one complication is the arterial puncture and formation of hematoma. You may ask this question in final MBBS examination, either in medicine, pediatrics, or in surgery. What are the complications of central venous catheterization? One is arterial puncture, another is formation of hematoma, another is injury to the pleura. Injury to the pleura. What will happen if you injure? External air go into the pleural space, cause pneumothorax. That is also a cause of respiratory distress. You can diagnose in the neck hematoma by your eyes, but you cannot diagnose pneumothorax. You have to auscultate. There is no air entry in that side, and you have to urgent portable chest X-ray. By portable chest X-ray, you can identify the position of the catheter and also the pneumothorax. If tension pneumothorax happens, you have to give immediate emergency intercostal drain. Another rare injury is if left-sided, injury to the nerve and injury to the other structures. All these injuries are less in internal jugular side, but in subclavian side, the chance of injury is more. And another disadvantage, if arterial injury in the neck, you can control it by pressure. If you injure the subclavian, you cannot control with the pressure. That is a closed space. You have to either drain it or open it. If infra-inguinal method is used in the femoral vein, you cannot control with the pressure, but above the inguinal ligament, you cannot control the pressure. Bleeding will be in the retroperitoneal space. Then you have to cautious about not to injure the patient. If occurs during the procedure, you have to abandon that procedure and give pressure for 5 minutes, if in the neck, or you have to go either portable chest X-ray or portable ultrasonography. আর কি আছে এটা ছোট করে বলে দিই, এটা তোদের অত লাগবে না। JVP or CVP venous tracing. একটু বলতে পারছি না, এখান থেকেই বলি। আচ্ছা, তাহলে এটা এখানে কি আছে? নিচেরটা হচ্ছে জুগুলার ভেনাস ট্রেসিং, 3টে পজিটিভ হয়ে আছে, ঠিক আছে? একটা হচ্ছে এ ওয়েভ, একটা হচ্ছে সি, একটা হচ্ছে ভি, আর 2টো নেগেটিভ হয়ে আছে, এক্স আর ওয়াই। এক্স ডিসেন্ট, নেগেটিভগুলো কি কি বলে? ওয়াই ডিসেন্ট। এটা কখন হয়? এ ইজ ডিউ টু অ্যাট্রিয়াল কন্ট্রাকশন। অ্যাট্রিয়াল কন্ট্রাকশন, কন্ট্রাকশন হওয়া মানে প্রেশার বাড়া, অ্যাট্রিয়াল কন্ট্রাকশন। আর সিটা কখন হয়? আর এ corresponds with the PO. P corresponds with the atrial contraction. PO is connected to the atrium, and rest QRS and T connected with the ventricle. QRS is ventricular contraction. T is ventricular relaxation. Ventricular relaxation. But why T is positive? It should be downward. ফিল হচ্ছে, হ্যাঁ, দ্যাট ইজ ফিল হওয়ার জন্য, হ্যাঁ, সে ফিল হচ্ছে তখন। Then A is for atrium. This is the right atrium contraction. আমি আর নিজে নিজে বলতে হবে, দেখে দেখে বলছি। ইট কোরিলেটস উইথ দ্য পিওএফ এন্ড দ্য ইসিজি, ঠিক আছে? অ্যান্ড মনে রাখার জন্য সি ফর কাস্প। হোয়াট ইজ কাস্প? কাস্প মানে লিভলেট। ট্রাইকাসপিড ভালভ, 3 কাস্প, each leaflet is called cusp. So C for C. How it happens? When during the isovolumetric contraction of the right ventricle, isovolumetric contraction means both valves are closed, both tricuspid valve and pulmonary valve, both are closed. So when the right ventricle contracts, tricuspid valve will shift towards the right atrium in closed state. If it shifts into the right atrium, then pressure increases automatically. That is called the second A wave or C wave. Correspond with the C for cusp, bulging of the cusp into the right atrium, bulging of the tricuspid cusp into the right atrium. C for C. Okay. Then comes the X descent. C corresponds with the end of the QRS in ECG. Because ventricular contraction, end of the কি বলছিস? 4 মিনিট। তাহলে আবার না, এটাকে আরেকদিন পড়ানো যায় না। আর হোয়াট ইজ এক্স ডিসেন্ট? মানে নিচে নামবে। তার মানে কি? হোয়াট দ্যাট মিনস দ্যাট রাইট এট্রিয়াল প্রেশার উইল fall, will decrease. When then what happens? Then ventricular contraction, no relaxation. Ventricular contraction and opening of the pulmonary valve. Then what happens? Right ventricle descends. Descends where? Towards the apex. Towards the apex. If right ventricular defects, it also pulls the right atrium and pulls the tricuspid valve towards the apex. And if it opens, the relaxation of the right atrium, relaxation of the right atrium. So X is relaxation of the right atrium during ventricular contraction. Keep to remember that it is X is for relaxation. Relax X. Okay. And it corresponds X with the ECG before the T wave, ST segment, before the T wave, from S to T. Before that, usually it is specifically before the T. Then comes V. V মনে রাখার উপায় কি? আবার রাইট এট্রিয়াল প্রেসার বাড়বে। It is the late diastole, sorry. that is P is early diastole, it is late diastole. What happens? Late diastole, there is filling of the right atrium, that is venous return, increased venous return, V for V. Increased venous return, there is increased venous return. This venous return hits the closed tricuspid valve and it backs the pressure, that is M. And it corresponds with the TOA. And and last is Y. What is Y descent? atrium pressure কমে যাবে, ফিল আপ হয়ে গেছে, ফিল আপ হয়ে গেলে এবার ডায়াস্টল হবে, ভেন্ট্রিকুলার ডায়াস্টল, ট্রাইকাসপিড ভালভ ওপেন হবে, ওপেন হলে ব্লাড যাবে, এটিএমটা ব্লাড যাবে, এটা এমনি ডায়াস্টলিক ব্লাড যাবে, নট কন্ট্রাকশন, কন্ট্রাকশন দ্য লেট পার্ট, when contracts into the late part of the diastole, ব্লাড গেলে অটোমেটিক্যালি হয়ে যাবে। এইবার হচ্ছে this is the normal, 2 and 1 points above the abnormal. Where you will get the absence of AOA? Also the atrial fibrillation, thank you, very good. Also correspond with the absence of the TOA. আর AOA prominent হবে কোথায়? রাইট এট্রিয়াল হাইপারট্রফি বা রাইট এট্রিয়াল প্রেশার ইনক্রিজ করলে তখন হবে। ডু ইউ হার্ড অ্যাবাউট দ্য ক্যানোনয়েড? হ্যাঁ, ক্যানন AOA, when the ventricle and atrium severely contracts simultaneously. When it contracts simultaneously, very rare, not for your syllabus. Complete heart block, junctional arrhythmia, AV dissociation, and ventricular tachycardia. These are things. And prominent here, remember, it is because related to the tricuspid valve. If there is leak in the tricuspid valve here, so more blood will come. Venous return তো হচ্ছেই, তার সঙ্গে এদিক থেকেও লিক করে ব্লাডটা এটিএমে যাচ্ছে, তার মানে আরো প্রেসার বাড়বে। That will be very tall VOF in tricuspid degeneration. That's a specific sign of central venous tracing or